My name's Tom Fries. I met most of you, I think, from the podium this morning, but I'm the Director of Training at the UCLA Integrated Substance Abuse Programs and the Director of the Pacific Southwest Addiction Technology Transfer Center. And I'm going to be doing this session today with one of the program directors who works with me, Dr. Sherry Larkins. And we've done training kind of all over the place on a variety of different topics, but over the last several years we've been focusing a lot on screening and brief intervention. And if you listen to Dr. Manderscheid this morning, it's pretty evident why screening and brief intervention is one of the topics that people are particularly interested in now. It is going to be a centerpiece of how services are going to begin to move toward integrated services. Now, one of the things that's complex about moving these systems together is that the systems haven't talked to each other in decades, maybe longer, and so they've developed their own way of doing business. And now we're kind of being crammed together in a really uncomfortable way sometimes. You know, what is it that you even do and why am I interested is one of the questions that we often ask. But once we figure out that we are interested and that there's a payoff for doing this kind of integrated services, we have to figure out how to talk to each other. And so the planning committee thought it might be good to take a look at how to take what has been shown to be an evidence-based practice, screening and brief intervention and referral to treatment, and look at how it might be used in conjunction with other evidence-based practices that don't necessarily address substance use. So we're going to use as a model the evidence-based practices that are being employed through the Department of Mental Health, the LA County Department of Mental Health now, but it really only serves as a model. The issue is really, how can I take what I do today and make it better by adding something else to it that addresses a scope that I'm not necessarily addressing. So in reality, the screening and brief intervention procedures we're talking about are simply motivation for change kinds of procedures. So if you're working on substance use, you could use them to help people deal with mental health issues. If you're dealing with mental health, you could help them address physical health or substance use issues and sort of develop motivation and movement in that direction. And likewise with both of the behavioral health issues to help people move to addressing their primary care. So that's our goal today, is really to sort of set the rationale for why we should be conducting screening and brief intervention. We're going to focus on medical settings because that's where most of the research is, but we'll apply it to a variety of different settings. We'll look at some specific screening procedures, including those that are used by the Department of Mental Health. Did I mention that they're one of the major sponsors? In fact, the major sponsor of this conference. And then we'll look at a specific brief intervention strategy that's based on motivational interviewing. And we really like it because it's really short, unlike some of those longer ones like FRAMES and the 9-step one that comes with the assist that I can never remember what the acronym even is. It's just 3 quick steps. It's highly adaptable and really flexible to a variety of different scenarios. So evidence-based practices in DMH settings, if we're going to talk about evidence-based practices, we should talk a little bit about what they are and what we mean when we talk about evidence-based practices. What we're really talking about is the integration of what we know from science and the best evaluated treatments that we have available, and folding those in together with clinical expertise and patient values. Now, one of the problems with this emphasis on evidence-based practice is we know there's a heck of a lot of practices out there that if we were collecting evidence on them, they'd probably do pretty well. But we don't have that kind of evidence right now. So one thing I would encourage you to do is think about how we could gather evidence on those practices, because more and more, as the payment system is going to work under health reform, we're going to be asked to show data. We're going to be asked to prove that what we do works. We're going to be asked to show outcomes that are effective. And in doing that, we're forced to rely more and more on interventions that have evidence behind them or evidence-based practices. So, treating mental health and substance use disorders is kind of a mess, right? It's complicated. You think you've got a handle on one thing and something else rears its head and you're like, where did that come from and how do I do this? There are programs that have evidence for helping people with these kind of multiplicity of complex issues. There are intervention models that work for some people and don't work for other people. So we never want to get into a situation like we thought we were going to get at one point, I think, where we're going to find the magic pill, right? We're going to find the next aspirin that cures everything, and it's going to be a behavioral treatment. We're never going to find that behavioral treatment. And in fact, what we need is more options and more treatments to treat the complexity of the individual sitting in front of us. So when this doesn't work, we can try that and hopefully be successful in that way. Some interventions have been shown to be more successful than the others, but it's really up to you to know as many of these interventions as possible that have this evidence-based support behind them so that you can use your fantastic creative clinical skills to address the needs of the individual that's sitting in front of you. The benefits of EBPs? Well, we have evidence anyway that they get positive outcomes and that the outcomes last for a while. That seems good to me. It avoids adverse consequences of under or over or even worse inappropriately intervening. If you just misdiagnose the person or you just give them the wrong thing altogether, surprise, it may not work. We want to avoid that as much as possible. We want to build on the strengths of the individual and build on hope, and a lot of the interventions that we're talking about are really strength-based interventions as opposed to what we used to have a lot of in the substance use field, which are really weakness-based interventions. You know, those old confrontational kinds of approaches. We tear people down to build them up. Now we just build people up to build them up, and that's been shown to be much more effective. They're cost-effective in that they've generally been boiled down to the most effective pieces so that we're not doing a lot of stuff that isn't necessary that costs us a lot of money in staff time and other kinds of resources. And as I said, we're going to have to show outcomes under health reform. I, as a clinician, hate that part. Right? I hate the data collection part, I hate all that kind of stuff, but I also feel good about it because isn't it time that we collected the information to show what we do works? Particularly with these really complicated, multiply diagnosed individuals. And if we can show that, then we show that we deserve to be where we are and to get paid well for what it is that we're doing, and hopefully in the process our pay scales will go up as well. We're hoping, right? So in selecting an evidence-based practice, you have to think about the patient population that you're treating specifically. You have to think about what you want the patients to be able to do. Are you expecting them to be cured at the end, or you just want them to be a little bit better, right? With screening and brief intervention, we ain't curing anybody. All we're doing is starting them on a path of motion, and that's all we need to do. If they say, I'm going to move toward change, we've had a successful screening and brief intervention. So our goal in this particular evidence-based practice is far from the cure, but isn't it the first step in the cure? And we have to think about our own readiness to implement it. How trained is your staff? How trained are you? Do you have supervisors who can support it? When you leave here today and you think about developing a screening and brief intervention program, what is it that you need to add to what already exists in order to make sure that it's successful? If we don't do that kind of preparation, the chances are we'll prove that it doesn't work, not because it doesn't, but because we haven't made ourselves ready to do it. Well, I told you I'd tell you the EBPs in the DMH system, and I don't expect you to be able to read this. I put it up just so you could see the number of lines. This is page 1. And this is page 2 of the evidence-based practices that are available in the Department of Mental Health for use with clients who are receiving DMH-funded services. I think this is a fantastic thing. Again, you're probably doing some or all of some of these, but the most important thing is we have a number of different practices that have a lot of evidence associated with them. And only one of these addresses substance use, and it's a secondary focus, not a primary focus. So you have all these evidence-based practices for mental health. What if they're using drugs? What do we do with them? Well, one of the things that we can do is begin to think about asking them and beginning to fold in change-related strategies associated with the other work that we're doing. I don't know why I put that slide in there. I beat it to death already. The good news is what we're going to talk about are approaches that work well together. Most EBPs are kind of intervention strategies, but you don't have to do them in their purest form. In fact, you can do this EBP combined with that EBP, and we haven't studied it in that way, but we know what this one does, and we know what that one does, so maybe together we'll get an even bigger bang for our buck. Or maybe we'll get the same bang for our buck, but we'll treat this individual even better. Screening and brief intervention can be nicely folded in with anything else that you're doing. I want to take a step back for a second and talk about substance use because how many people work in the mental health side of the field? Wow. Okay. How many people work in the substance use side of the field? How many people work in the health side of the field? A few of you, good. How many people work in all three sides of the field? Just a few of you, okay. Most of the hands that went up were mental health. So for those of you who work in substance use, this probably won't be surprising to you, but it might be a nice review. This is a pyramid of 100 people. If you ever want to make a pyramid of 100 people, steal this one because it took me a whole lot of hours to make. But it does represent the population of the US just prior to the last US census. I use those numbers because it's what my other data lines up with. And what we find, if we look at those people who are receiving treatment for substance use service, we get just about 2 million people who are in treatment for substance use. Just under 1% of the US population. There are another 21 million people who on a national survey, phone-based survey, answer questions such that they probably have a diagnosable substance use problem, but they're not in treatment currently. So this is a pool that we need to tap into because they're likely having other mental health issues and they're likely having other primary care issues as well. Now, no one really knows the next number, but the best estimates I was able to come up with are another 60 to 80 million people who use substances at risky levels. They don't have a problem yet, but if they keep using like they are, they're gonna. Now, this is the people that we're treating. Who the heck are the rest of these people? Let's spend just a second identifying them. First of all, the people that we're treating, where do they come from? Well, this is LA County data, and it's interesting. They come from a variety of different places. 25% criminal justice. Some of those go to the county assessment centers first. So we got another 20% who come from those. Many of those are criminal justice involved. Does anyone notice a number that sort of stands out? Because I highlighted it. What's up with the numbers in the healthcare system, right? 3% of patients in the healthcare system have substance use problems. Does that sound like the right number to you? 3% of people who need treatment are in the healthcare system. No sense whatsoever. Something is broken down, right? We're not making the connection between people going in over and over and over for a stomach that's all acidy and burny and got ulcers burned in it, and the fifth of vodka that they're drinking every night. You laugh, but we miss it. And we miss it in the mental health settings as well because we don't think to ask. We have to ask. That's our first lesson. Second, those people who have a diagnosable problem but aren't in treatment so far. People say, well, that's our waiting list. That's why we have such long waiting lists. Turns out not so much. About 1% made some effort to get into treatment of those people. That's our waiting list. Another 4% said, yeah, maybe I have a little bit of a problem, but I didn't do anything about it. So they were at least aware of it. 95% said, what? What problem? I don't have a problem. I don't know what you're talking about. Even though they answered questions in such a way that they probably have a diagnosable substance use condition. Well, where are those people? They're floating around in the medical system. They're floating around in the mental health system, needing to be identified. Then there's the risky users. These are the people that slip through the cracks all the time. It's the person who drinks 3 to 4 glasses of wine a few days a week. Well, that's over what the National Institute on Alcohol Abuse and Alcoholism says is risky levels of drinking. Do they have a problem now? Probably not. Do they need treatment now? Probably not. But a brief intervention designed to help them to lower that number a little bit, maybe down to 1 or 2, may save them from needing a treatment episode in the future. It's the pregnant woman who gets a little stressed out every once in a while and has a shot of vodka to take the edge off. Is she an alcoholic? Probably not, right? How much alcohol is okay for a developing fetus? It turns out the real answer is we have no idea. We know a lot is bad, but we don't know what that number is that goes from a little bit to a lot. So the recommendation is 0. She's putting herself at risk. She's putting the developing fetus at risk. It's the adolescent who's the quarterback of the football team and getting great grades, but spending every weekend in his room with his friends smoking bowls and playing video games. No problems yet, but needs to be identified. Or the woman who takes Vicodin for legitimate back pain, and every once in a while when she's at work, her boss makes that pain move just a little bit south, if you know what I mean. And she takes an extra Vicodin to take that edge off as well. Again, not a diagnosable problem, but if we don't identify her, it could quickly become one. So these are people who will never darken the doors of a substance use treatment program, but they'll darken your doors a lot. And if we can identify them using some fairly simple procedures while they're showing risk, we can do really primary prevention. We can prevent them from going on and developing a disease that they don't need to get. That's our goal. Now, screening and brief intervention works. I sometimes spend like half a day on just these 2 slides that I'm going to show you now. So I'm going to cover them in really cursory ways. But in looking at a summary of the data for screening and brief intervention, the impact is unbelievable. Larry Gentilello, who's the godfather kind of screening and brief intervention, found in a study that he did among trauma patients 48% fewer re-injuries over 18 months among trauma patients. 50% less likely to be hospitalized if they got a simple 5-minute screening and brief intervention prior to being released from the trauma center. In a hospital ER, they found that for every 9 screens that they did, they prevented a drunk driving arrest. Not a criminal justice environment, a hospital ER, and they were preventing people from killing each other on the road. 20% fewer motor vehicle crashes in a physician's office study. In several meta-analysis studies, they showed increases in quality of life. They showed increases in health and functioning, increases in job performance. All this from a tiny little intervention, it seems crazy. And yet, it's absolutely borne out by the data. And most important under health reform, it saves a truckload of money. The UK study was on a brief treatment, a longer episode than we're going to talk about today, so it's more expensive. But they found for every dollar they spent on that brief treatment, they saved $2.30, converted to US dollars, $2.30 in savings. In a couple of brief intervention studies, the cost savings ranged from $3.81 to $4.30 for every dollar spent on screening. Now, this isn't cash back in people's pockets, but it's diabetes care that they don't have to provide because their diabetes goes into control. It's 3 less office visits because they're not feeling bad and they don't come back again and again and again. So it's cost offset dollars that they can spend then those resources on other kinds of services that are needed within the patient population. Saves money, and it works, and it's simple, and it's quick. Seems like a pretty good argument for doing it. One of the things these screening procedures do is they make it a little bit more like a laboratory test. We draw blood, we get a number on the back end, we give the number as a report, we figure out whether there's something to do there or not. So we draw their blood every once in a while until we get a positive test that we need to do something about. If we confront them harshly, we lose them to treatment. If we accept that they may not be ready yet to address that issue, but we can find a way to preserve that relationship, turns out they tend to tell us at some point when they're ready to begin to move in that direction. And how we ask that question and how we respond to their answer is huge in terms of whether or not they're willing to continue talking to us about those issues or not. And that's where motivational interviewing comes into play. So we're going to talk a little bit about motivational interviewing and some of the specific skills that we think are most useful with this kind of intervention, because it is the way to get people to fess up, and it is the way to get them to begin to move toward change. So there's a partial answer to your question, and I'll answer it more fully as we go along. You look like you're disbelieving now. I don't see it as rhetorical at all, though, can you see? Because I think that is the divide that we have very often. We feel like we can't get anywhere, so we often use that as a reason not to ask the question in the first place. And if we feel empowered that whether or not we get anywhere, we're making movement, then there's no reason not to ask the question. And I'm going to show you some of those procedures in just a minute. Anything else? Okay. A few different kinds of screeners. There are biologic markers, certainly. We can take a blood test, we can take a breath test, we can take a pee test. If we can take those tests, why don't we just use those? That's not a rhetorical question. Why don't we? So we might find a positive result, but then what the heck do we do with it? Because they're going to tell us where to go with that positive result. Good. Why else don't we just use these biologic markers? Yeah.
It's not friendly. It doesn't build a relationship. It's kind of almost punitive.
Not friendly, almost punitive, and you have to watch someone pee or stick a needle in their arm. It seems kind of invasive too. Yeah. How long do these tests last for the most part? Depends on what we're talking about. Alcohol, the body consumes about 1 standard drink an hour, so a few hours later, you're not going to have any alcohol in your blood. With most other drugs, you get about 72 hours, about 3 days. With fat-soluble drugs like marijuana, you might get out to a month. But someone falls down and breaks their leg because they're drunk and were high at the same time. They crawl home in agony for a few days, wait till the drugs get out of their system 3 days later, come back with a worse fracture, but you don't know what happened. And they say, I don't know, I was really clumsy and then I couldn't get to the doctor and it's been 3 days and wow, that was stupid. We missed the opportunity. So, biologic markers are good, but they only give us an immediate picture. What we get when we ask self-report measures is a history and a relationship. We begin the conversation and don't get too invested in what they say in response to us. Now, there are some characteristics that we want in a screener. They need to be brief, and that's defined by the World Health Organization as 10 items or less. Most people say 10 items, forget it, I'm too busy, I don't have time for that. So I'm going to show you a shorter version than that as well. But a lot of the screeners that are used do follow that rule of 10 items or less. They need to be flexible so they can be used in a variety of different contexts. They need to be easy to administer for you and for the patient. They need to address alcohol and other drugs. That's a huge deficit that we have. Most of them address alcohol or other drugs, not both. So if you want to cover both, you have to double the number of questions you're going to ask and ask 20 questions, 10 for alcohol, 10 for drugs. DMH came up with some creative ways around that. I'll show you in just a sec. It should indicate the need for further assessment or intervention, and it should find a problem if it exists and rule out the problem if it doesn't exist to the maximum extent possible. We covered that. Here's a partial list of screeners. I think I only included these because they're the most common ones, not because they're the best ones, but we probably have the most robust data on these. The ASSIST was developed by the World Health Organization. It's the most comprehensive, and you'll see it's only 8 items. That is the biggest lie ever told. It's 8 items for every category of drugs the person has used. So if they've only used 1, it's only 8 items. If they've used 6, I don't do math, but I think that's 48. Right? So it can be a lot of questions depending on how involved in drugs they are. So many people use it, but they do a pre-screen that I'm going to show you in just a second first. The audit only addresses alcohol. It's 10 questions. There's a shorter version that's 3 questions as well. The DAST only addresses other drugs, not alcohol. 10 questions. So many people, again, will do a pre-screen. And if they test positive on the pre-screen for alcohol, they'll give the audit. If they test positive on the pre-screen for drugs, they give the DAST. But they know they're more likely to find a positive result in that case. The CRAFT is the most widely used one for adolescents. And all of those are in the public domain. If you ask the questions, does the instructions say yes, it does. So it's about misuse of prescription medicines and or use of illegal substances. But many people forget that and they only ask the questions about illegal drugs, and so they don't include that in their screening. Good question. DMH came up with what I think is a really novel approach, and they adopted the Co-Occurring Joint Action Council's screening tool, and it's broken up into three sections: 3 questions on mental health, 3 questions on addiction. It's actually the audit C, so it has some pretty good reliability data behind it. And 3 questions based on trauma. All of them have come from other instruments that have been validated, although these are abbreviated versions. That's used as a pre-screener that then leads to use of the standard adult admission forms. So, and co-occurring disorder assessment forms. So if they test positive on that screener, then you ask them about alcohol and all of these other drugs, and we begin to get a more in-depth history. DMH employees, and I would recommend that all employees be taught that if you're talking about drugs, you should think about primary care and mental health, so that as you're asking about all of these drugs, you think about mental health symptoms associated with those forward and backward. Someone comes in for depression, maybe I need to think CNS depressant as well as depression, but someone comes in using a lot of alcohol, maybe I need to think depression in that regard as well. Likewise, you should be thinking about medical consequences that they may be having, like cirrhosis of the liver, high blood pressure, diabetes, all of those diseases that are associated with use of these substances. So now we have to move from being specialists, maintain your specialty, but we need to become more generalists as well. We need to understand what the other disciplines are going to be looking for so that we can at least highlight the important points of those. It's more the adult initial assessment, and again, it's kind of the same thing. If you see someone with head trauma, what led to the head trauma? We may think about substance use. If you see someone with hypertension, are they using lots of stimulants? So we begin to think about other things that may lead to these kinds of physical problems as we're assessing for their primary care related issues. And suddenly, we're doing a broad spectrum screening rather than just filling out a form that may not be particularly useful. The other thing that we have to keep in mind when we're doing screening is how much can they use? These are the levels, according to NIAAA, of risky drinking for men and women. No more than 4 drinks per occasion or 14 drinks per week for men, no more than 3 drinks per occasion or 7 drinks per week for women, and no more than 1 drink per occasion or 7 drinks per week for all older adults, regardless of gender. The first question, why do women get ripped off? What's up with that? I can have 2, Sherry can only have 1. Ah. What's up with that? Does anyone know? Yeah, the body metabolizes alcohol differently. There are different levels of enzymes and there's different ways that they move around the body, so that a woman who drinks the same amount will end up with a higher blood alcohol content than her male counterpart, even if everything else is equal. So we have to watch that and pay attention. But the other thing that we need to pay attention to as we move toward older adults is guy comes home, has two beers every single day after work, 5 days a week. Nothing on the weekend. 5 days a week, 2 beers a day. 5 days a week, 2 beers a day. Turns 65, moves from a low-risk drinker to a high-risk drinker by having a birthday. So suddenly lifetime patterns become problematic because of the change in metabolism and body functioning of the individual as they exist. And remember, a beer is not a 40. A 40 is 3.5 beers. They have been standardized. A beer is 12 fluid ounces. A glass of wine, 5 ounces. By the way, in most standard wine glasses, that looks like that much. Most people pour about 8 to 10 ounces when they pour a glass of wine. So you're pouring 2 drinks into that one glass. Hard liquor, you get 1.5 ounces or a jigger. A Long Island iced tea can have anywhere from 2 to 5 standard drinks, depending on who's poured it, in that single glass. We need to move beyond the container to what people are consuming. That being said, how much crack can you have and have it not be risky? Heroin? 1 pipe. Yeah, I like it. Just 1 little line of heroin's okay, but 2, that's off the table. Of course, with other illegal substances, by virtue of the fact that you use, you're engaging in risky behavior, putting yourself at risk for legal as well as other medical and other kinds of complications. So we get a little bit of leeway with alcohol, but no leeway with other substances in terms of level of risk. So a variety of different screeners, but I'm going to recommend, if you're going to implement a screening and brief intervention program, that you do a pre-screen first. And that pre-screen should be evidence-based. And it turns out Richard Sates developed a one item for alcohol and a one item for other drugs that show really good concordance with some of these long screeners in terms of their ability to capture people who are using at risky levels. So the question for alcohol is, how many times in the past year have you had 5 or more drinks if it's a man, or 4 or more drinks in a day if it's a woman? Because we get more leeway with alcohol, any number greater than 1 is a positive screen and needs more careful evaluation. It doesn't mean they're an alcoholic, it doesn't even mean they're using at risky levels. What it means is there's an indicator of risk and we need to evaluate that further. So you might do the audit, or you might do the audit C that's contained in the DMH paperwork. More careful evaluation. For drugs, how many times in the past year have you used an illegal drug or used a prescription medication for non-medical purposes? Important distinction, right? Again, here, we don't get any leeway. Any number 1 or more is a positive screen and needs more careful evaluation. Yeah, and this needs to be interpreted, because for non-medical purposes means using someone else's for my back pain, so as prescribed but not prescribed for me. It means using more than I was prescribed, and it means using it as prescribed and for other reasons too, right? So we need to capture all of those.
A lot of people come in with medical marijuana cards.
Yes, sir.
Consider that medical.
Yeah, I'll get to that in 1 second. What's your question?
Do people really think that people are being honest? I'm a recovering drug addict who self-hospitalized several times.
Yep.
And I would never answer that I was doing drugs.
Great. Except for that provider that you eventually did answer that you were doing drugs with. Okay? So you found a way to do it. The issue is often very much the fact that we don't trust our providers, right? What if you had a relationship that you actually trusted your provider and thought that they had your best interest? They weren't going to send you off to jail, but that they were going to actually help you with the situation. You may lie to them a whole bunch of times, right? But eventually, you might tell them the truth. It's the same question that you were asking in the back of the room. It's about the relationship and establishing the relationship and how we ask these. Well, how many times in the last year have you had 4 or more drinks in a setting, Missy? Is a very different question than, let's talk about your alcohol use. Has there been any time in the last 4 years, or when you've had 4 or more drinks in the last year? Yeah, that's happened a few times. How many times would you say that's happened? So that non-judgmental, non-confrontational approach increases the likelihood that over time you'll begin to answer the question. And by the way, when my own doctor asked me about my alcohol use, I'm not in recovery. I drink a glass of wine, actually fairly frequently. A 5-ounce glass of wine, I actually do measure it, because I pay attention to this stuff. And yet, I didn't tell my own doctor how often during the week I have that 1 glass of wine in the evening, because everybody assumes, well, if it's 1 little tiny glass of wine, he's having 15 glasses of wine. I know he is. So he probably needs a problem. So of course our patients will lie to us, but they'll also tell us the truth. And I told her the truth and I lied to her. And it turns out we have a really good relationship that has grown in trust across time. Medical marijuana. It's a tricky one, right? Because what if it's legit? Marijuana is good medically, and it is approved for recommendation for a variety of medical issues. So what I do is the same thing I do with opiates. I say, do I think this person is getting really good medical care, or did they go to a clinic on Venice Beach where they offer to give you $25 if you don't get your medical marijuana card? Well, looking at the indication for that medical marijuana card is really good. It's for nausea related to HIV. Okay, that sounds like they're getting good HIV care. Who's your doctor? I trust that doctor. Could I talk to them and could we collaborate? My eyelashes hurt. A real recommendation I saw once. Isn't that alarming, right? We got them a new medical evaluation and found a way to deal with what was actually legitimate pain in a very different way that the marijuana was actually contributing to in ineffective ways. So I treat it like opiates. And I think, does it sound like you're getting good medical care? And if not, I see how willing the person is to move toward medical care. And the more resistant they are to help to really address the situation, the more I go, maybe they're not being completely honest and we need to work on some motivation. Brief intervention. Brief interventions work, and they're brief. That was it. They're not going to fix people. They're just designed to push people on a path toward movement. That's all. Okay? We want to start them in the process of change. That's ultimately our goal. And the way that we do that is we get them to come up with the idea. Pascal. People are better persuaded by reasons they themselves discovered than those that come into the minds of others. No matter how brilliant you are, doesn't really matter if the person doesn't want to hear it. But they're brilliant to themselves every single time. So if we can find a way to help them be brilliant for themselves, they've sold themselves on making change, and that's what we want to do. So brief interventions trigger change. A little counseling goes a long way. There was one study that was done through the NIDA Clinical Trials Network, and they showed that during a standard evaluation, just 5 minutes of motivational interviewing at the beginning and 5 minutes of motivational interviewing at the end significantly increased the number of people who were in treatment 30 days later. Be nice to people, they tend to stay around. Respect them, they tend to stay around. Most of the research has been done on alcohol, but there is promising research on use with other illicit drugs as well. We need to pay attention to the stages of change, and this is not an MI training, so I'm not going to spend really any time on the stages of change, particularly since I only have 10 minutes left. But knowing where people are in the stages of change becomes really critical. If you're not familiar with this, Prochaska and DiClementi, the reference is there. It's really interesting. But what it says is, we start change going, I don't know what your problem is, I don't need to change. That 95% who have a problem who don't recognize it. Our task is to raise their awareness so that they can begin to contemplate change. I'm thinking about change, there's something to change, but I feel ambivalent about it. Want to change, don't want to change, like the way I am, don't like the way I am. We help them resolve the ambivalence in favor of change. They make a determination to actually do something. You notice we haven't taken a single action yet. But they decide what they're going to do, and they move into the action phase, which is where treatment occurs. They do really well in treatment, they make all their goals, they move on to the maintenance phase where they have to learn to live their lives with all the changes that are there. And for some people, they have what I like to call a recurrence, traditionally called a relapse, right? It's just a recurrence, it's just an exacerbation of symptoms, as opposed to a relapse, booga booga, right? Where that person is bad and they've done something wrong. So what people will make the changes in this particular order, sometimes fast, sometimes really slow. Our job is to kick them into the next stage as quickly as possible. By the way, this is a nice little job aid. It gives you some really specific things you can do. You can print it out double-sided and you go, I have someone in pre-contemplation, they don't want to talk to me, what can I do? Well, I could offer them some factual information. That might be useful for them. So print this out and put it on your desk, it's really helpful. But the hallmark of what we're talking about is that ambivalence is normal. If you think about any change that you've ever made in your life, you probably had that feeling of, really? Do I have to? I know it's important, I really don't want to. If we can recognize lack of motivation as unresolved ambivalence and help them move toward resolving that ambivalence in favor of change, we have a motivated patient. Isn't she fabulous? I love my little animations. I won't tell you how long that one took me. Really, ultimately, we want to offer skillful reflections and we want to avoid confrontation. That's what we want to do when we talk to people. Sherry, I'm going to turn it over to Sherry in just a couple of minutes, and she's going to walk you through a series of steps that will help you engage in a process to increase the likelihood that they'll talk to you after a screening and that they'll move toward change. But ultimately it boils down to skillful reflections, tell them what you heard them say so that they can hear it again, and avoiding confrontation. I want to show you and intervention done.
You had a serious car crash. You're lucky you didn't kill yourself or somebody else. What do you intend to do about that drinking problem?
What drinking problem? Look, I had a couple of beers, my friends, that's all.
Your alcohol level was 190. Clearly you had more than a few beers. Now, how much do you really drink each day?
Look, I had a few beers with some friends of mine after work. What's the big deal? Everybody does. I mean, I work hard, and having a couple of beers helps me relax after a hard day. This time I got a little careless, that's all. Just so let's not make a big deal out of nothing. Just finish sewing me up so I can get out of here.
Look, I'm an ER doc, and I think I know when somebody's an alcoholic, and I think you have a serious drinking problem. You better straighten it out. Now, you can get out of here as soon as I stitch you up, but in the future, do not drink and drive. Have some sense, huh? I mean, next time you might not be so lucky.
What was good about that? That's what was good about it. Did everyone hear? Say it again. He raised the subject. That is much better than not raising it at all, even if you do it that badly. Right? By the way, that's a real transcript. Those are actors, but it's a real transcript from an actual clinical interaction. It happens a lot, particularly as we get busy and we want to fix people, right? You got a problem, let's fix it, here we go. And all of a sudden, we end up sounding like that. By the way, I've heard myself sound like that with the patient. Got to admit what works, got to admit what doesn't. What was missing is reflection. Reflection that shows the empathy for the provider to the patient, that shows true understanding. Many people think of empathy as just sort of showing the person that you understand. But the true definition of empathy is literally putting yourselves in the shoes of the other person and experiencing life through their eyes. If we can think about what it felt like to be that person and give him back that understanding, suddenly a relationship is formed that is founded in trust because there's mutual understanding. How's that guy feeling, by the way, in the bed? Frightened, guilty, what else? Anxious? What? He just wants to leave. He's mad. He's defensive, right? All of those are things that we could give back to him in an empathic statement, not a confrontation, just showing understanding that would increase the relationship. I'm going to, again, it's not a training in motivational interviewing, so I'm not going to spend a lot of time on this. But if you don't have specific training in MI, learning to do skillful reflections is the best thing you can do to improve any clinical work that you do. And not wagging your finger at people. Well, if you don't, like that guy did over and over again. Ultimately, what we want to do is listen for what we call change talk. And change talk is any indicator that the person is willing to move in the direction of change. That's what we want to hear, and that's the goal of our brief intervention. A really fantastic way to do that is the decisional balance. Now, the decisional balance, when done completely, asks the good things about using drugs, for instance, or whatever the problem is, the not so good things about using, the good things about changing, and the not so good things about changing. You simply have that conversation, you know everything you need to know. This is what I get by doing it, this is the cost I pay, this is what I would want by changing, and this is the cost I don't want to pay. It turns out though, if we spend a lot of time on this, the good things about using, it triggers the person. And they want to use more. And there's really good brain data that's come out in the last few years, and Bill Miller has reversed himself on this. So now what he says is, give them the good things, let them fill in anything that they think is important that you missed, and move right to the not so good things. So a lot of people, you know, they get relaxed, they feel good, they get a good experience, they have fun with their friends when they drink. Does that happen for you? Yes. Well, is there anything not so good? And you explore that side. And it seems to work much more effectively. Let's look at another example.
Okay, Joe, let's see what we got here. You had a pretty bad crash. Do you remember what happened?
Not really. I remember leaving the bar. The rest is pretty much a blur.
So you're unable to remember your injury. because of being in the bar.
Yeah, I guess so.
Sounds kind of frightening.
Oops, did you hear that? Sounds kind of frightening. What a great intervention. Reflection that really relates to his status of being at the time. Sorry about that, I didn't expect that to happen. Let's try that again.
Okay, Joe, let's see what we... Well, help me understand what drinking does for you. What is it you enjoy about it?
Look, I work hard during the week, and having a drink or two after work helps me to relax. I mean, a guy to cut loose every once in a while. I mean, my friends go out a lot, and I like to hang out with them.
So it's a way of relaxing and enjoying being with your friends.
Yeah.
Well, I can understand that. Everybody needs to unwind. Now, are there any things that are not so good about your drinking?
Decisional balance.
Not really. I mean, I have trouble getting up some mornings. I can't think straight for most of the morning some days.
Must make work more difficult.
Yeah, I mean, the day starts out kind of hard, but I just, stick it out. Try to push a little harder.
Sounds tough. Are there any other drawbacks to drinking?
Crashing my car is kind of a drag. I need the car. And having to get sewed up like this isn't too much fun.
No, I imagine not. But we're just about finished here. And that should do it. So, on the one hand, drinking is a way for you to relax and you enjoy doing it with your
Exploring
friends.
the ambivalence on the one hand.
On the other hand, it makes getting up in the morning more difficult. Wrecking your car and having to be stitched up in here, well, those are other painful consequences. So where does that leave you?
Where do you want to go? And we
Is I can
toward
cut down,
change talk.
on the drinking a bit, especially during the week.
I think that sounds like a terrific idea.
And then he moves on and he talks about how some people can do that on their own, but he may find that he can't. So they agree he's going to try to cut down and then have a follow-up visit when he comes to get his stitches taken out to see how that's working and if he may need some additional resources. So he moves in the direction of change talk. Again, this is a real transcript. This is a real client-patient interaction that happened in about 3.5 minutes is what you saw. What he did is he provided the person feedback about his current situation, and then he did the thing that we all so often miss. He took a few minutes to listen and to really understand the patient's perspective before he explored options for where he's going to go. So I'm going to turn it over to Sherry, and she's going to walk you through those 3 stages of the brief intervention, FLO, and give you a tool that you can use to intervene with any client regardless of the other services that you're providing around an issue that they're stuck on, something that you think they need to change that they don't necessarily want to change.
So as Tom said, I'm going to walk you through 3 steps of the flow brief intervention. Now, there are times that we actually spend a day going over how to actually do, and we practice each of the steps. And so we're giving you the 30-minute or 20-minute quick and dirty of what these steps are. But I think the important thing is that particularly under health reform, where we're working in more integrated settings, this is something that providers of all levels, nurses do it, doctors do brief interventions, peers do brief interventions, LCSWs, MFTs, a variety of staff level can do brief interventions. And they really are targeting or can target when you're doing an additional intervention. So if you're providing a mental health intervention, how can you also layer on a screening and brief intervention on top of that? So as Tom said, we're really talking about 3 steps. There are a variety of different brief interventions, and they all rest on a motivational interviewing platform. Another thing that Tom mentioned is that we often miss a particular step when we intervene with people. And when we get in very busy environments, we often go from providing feedback, something is wrong, something isn't working for you, this is what we think you should do about it. And we miss this most important step, which is where we really need to spend most of our time. And you saw the guy in the video, in the second video, spend a bit of time really exploring and using some motivational interviewing skills to try to move toward change. Now, Tom also mentioned earlier, and I think it's important to know that brief interventions are nothing more than an agitator. They irritate, they get the client, they stimulate the client, they get the client thinking. And if a client leaves a brief intervention just thinking that they may have to make some change, or even having drawn the slightest connection, if we've moved them from contemplation, pre-contemplation to contemplation, we've had a very successful brief intervention. So when we think about how it all fits together, I'm going to put all of this up here, there's a feedback piece, a listen and understand piece, and the options explored, and I'm going to walk through this. There are a variety, as Tom mentioned, of different brief interventions that all have multiple steps. I think flow is useful because it combines some of those, the 9-step and the 5-step and the 4-step brief interventions into 3 steps. So the first thing that we do during a brief intervention, and another thing that I sort of like about this brief intervention is there's flexibility in it. So when you, if you think about the video, the physician actually began some feedback, but he really moved to engagement quickly. And then even later, he moved to feedback near the end. He sort of reinforces the feedback about what are drinking limits that are acceptable, where his drinking limits fell and how it was sort of outside of it, it was in a risky range, and maybe what he could do about it. So we should think about these steps as being flexible in some ways, particularly if we start to notice clients getting defensive or if it's really hard for them to hear certain feedback. We may have to move to that more MI piece to continue the engagement before they're ready to hear the feedback about their risk. So we start right here with feedback, and this is really sort of setting the stage, and it's really sharing screening results. I like to think of a feedback piece, and we'll go in a little more detail, but I like to think of the feedback piece, and particularly the settings that many of you are working in, if you're working in integrated care settings. When you go to your primary care physician and you get your blood pressure taken and they give you the results back. If 120/80 is normal and you have 140/100 or 140 even over 90, you would expect your provider to give you feedback that your score fell outside of what is considered a healthy range. You would expect that feedback. You would expect to hear a provider share in a non-judgmental way that I have some concerns about you because your blood pressure falls outside of what's considered a healthy or normal range for blood pressure. We should think of the delivery of our screening results around substance use, and sometimes this is other behaviors as well. Brief interventions, we're talking about it with substance use today and how it folds in with evidence-based practices that focus on mental health. But brief interventions have been used for smoking cessation, for weight change, for a variety of health behavior changes. So we're going to set the stage by telling screening results. We'll talk about how to do that. And then this is kind of the meat or the heart of a brief intervention, which is that motivational interviewing piece. We'll talk about a little bit about weighing those pros and cons and a couple of little skills or tricks that you can use to try to get the clients to engage in more change talk, thinking about the possibility of change, the hope of change, and what change may look like for them. And then finally, we'll follow up with how to explore options. So the feedback piece. All right. We call this a feedback sandwich. I think it's just inherently respectful to ask people want to hear what you have to say. So starting with, you know, I have some feedback from your screener that I think might be important for you to hear. Is it okay if I share it with you? Getting permission, then sharing the information, and then saying, what do you think about that, or what are your thoughts about that? So really getting their buy-in from the beginning and allowing them the option to say, no, I'd rather not hear it, or no, I'm not interested in hearing it. You know, in doing brief interventions, it happens, maybe, you know, with adolescents or other people who say, yeah, I'm not really interested in hearing, but by and large, people come around and say, yeah, what were you going to tell me, or what were your thoughts anyway? But mostly people will just be thankful or that you've respected their autonomy enough to sort of ask for permission before you share feedback. So this is just a suggestion in some ways of how to cover results. I'm going to put all of them up here. But in in some ways, if you have a screener that is scored, for example, that has a score, many screeners have an actual score at the end of it. And they'll give a score like the assist or the audit will say, you know, if someone scores a 0 to 7, they're in a very low risk range, just do positive reinforcement. If they're in a range of an 8 to a 14, they're starting to use at some risky levels. You should do some sort of brief intervention and suggest reducing their use. And score of this to this suggests that the goal of your brief intervention should be more about trying to link them to a higher level of care. It should be more about referring them to more intensive services or a higher level of treatment. So, you know, some things that you could consider saying are, you know, the range of the score on the audit ranges from 0 to 40, and most people who are social drinkers score less than an 8. Your result was an 18 on the alcohol, which suggests that you are in a moderate to high risk range. And some of the standard screeners have norms attached to them and some of them don't. But the goal is that at this level, it's putting you at risk for a variety of health issues. What do you make of that, or what are your thoughts about that? In the same way that if you got a liver lab count or you've got blood pressure results that seemed like they were outside of a normal range, you would expect your healthcare provider to share it with you in a concerned way. Your patient should expect that you would share this information to them in a supportive way. Anything you want to add, Tom, to that?
No, it turns out, though, that if you just ask them for permission, they're more accepting of the feedback and more likely to talk to you after the feedback.
This is just an informational brochure. Sometimes, depending on the setting that you're in, you know, I've primarily worked in substance abuse treatment. Tom has worked in a lot of mental health settings and substance abuse treatment settings. As someone who works in treatment, I don't always see clients. In fact, I almost never see clients who just need to reduce their risk. I see people who need to stop. I've seen people who have tried to reduce from 2 bottles of wine a night, and then it's like, well, now I'm down to 1 bottle, and then they're back to 2 bottles. There are people who don't want to smoke crack every day, but they'll only smoke crack on weekends, and then they go back to their regular pattern. For many of the people that you're catching in your settings, if you will, that we're able to sort of capture their risk levels, these are people who may be just needing to reduce risk. They're drinking 3 glasses of wine a night, and they need to reduce to 1, and having that conversation. It feels, I think SBIRT feels really sort of awkward for a lot of substance abuse treatment counselors because we're not used to having those conversations where it's more harm reduction focused. We're used to sort of the abstinence model.
But we could use it for depression, or we could use it for anxiety, whereas we won't use it necessarily for drugs.
Great. During the feedback stage is probably where, if you're going to get resistance, maybe if you forget to ask permission, or you start to sense that the client is uncomfortable and not sort of on board with you providing this feedback, this is probably where you're going to get some resistance, where the client might say, you know, my dad was an alcoholic, I'm not like him, you know, what are you trying to tell me? I'm an alcoholic, I just like the taste, I could control my use if I wanted to. And so some of what we have to sort of consider is the clients that we're working with come to us with a variety of different issues. And I think many of them are going to fall into the category that Tom mentioned very early in his talk, that 95% of the people that are using at risky levels that could benefit from some type of service, but they're not getting service because why? They don't think they have a problem. They don't see that they have any issue. And when we think about the clients that we see that come with a variety of issues, the complex issues that our clients see, they have substance use issues potentially, they may have chronic pain or chronic medical conditions, they have mental health conditions. And when they come to us, they may be talking about the thing that is the most bothersome to them. They're coming to an FQHC, they're coming to a health center because they need a pap smear. They're coming to an FQHC because they have back pain. They've broken a bone. The variety of reasons they come to us, they have chronic pain. They want to talk about that, and that's why they're there. So we have to be thoughtful in how we start to draw the connection between that and a substance use issue, or that and their mental health issue, because they may not be ready to hear it. So we have a client who's there to talk about chronic pain, and we say, wow, your screener shows that you have problems with drugs and alcohol. And they say, actually, I have a pain problem. And we say, yeah, but we think you actually have a substance use problem. And we start this chase with our client where we're not really meeting them where they're at. And we're also not, we really have to think about ways in which we can bring these 2 or 3 issues together. We know that their chronic pain issues are potentially exacerbating their mental health issues. Substance is layering on top of that. And so sort of disentangle this for the client can be challenging to hear or difficult for them to hear, and we have to be thoughtful in how we continue to approach that. So we want to avoid this sort of struggle from the beginning where we could potentially lose the client. We want to continue to sort of engage them, and this is where some of the motivational interviewing can come in to continue to engage the client. Because one of the important things is that we do need to let go when we see this happening. We have to reassure them that really our job as their provider is, and in some ways we would be remiss if we didn't address it with them. Just as if you had gotten some other medical result and your provider didn't share it with you, you would think that they weren't doing their job. It is part of our job to share information when somebody's risk use or risky levels or their care, the behaviors that they're engaging in are sort of outside of a range of what's considered healthy or normal. And so a lot of times it's really reassuring them that what you do is up to you, but part of my job is to share it with you. I'm your healthcare provider, I'm your provider, and I care about you, and I think it's important that you have this information. This finding a hook is also really about the sort of, I guess we call the slide the dancing bubbles, the client that we chased with substance use, and the client was really wanting to focus on chronic pain as opposed to a substance use issue. We really need to find the hook for that client. We need to sort of find what are the patient's concerns? What are they worried about? They're worried about their pain. They're worried about what's happening in a variety of aspects of their lives. We need to listen to them and find that hook so that we can start to bring both the substance use issue as well as the issue that they are there to talk about, whether it's their mental health issue or whether it's a health care issue, that we can bring these together for them. And in some ways, it's really listening for signs of their discomfort with the status quo. You often start to hear clients become dissatisfied with ways in which life is going for them. So they may share that it might be a relationship issue they're having at home. It might be a financial issue that they're having. Some of which are connected to the healthcare issue or the substance use issue. So it's listening for those and watching for those signs. And it's also directly asking the question, what role, if any, do you think alcohol has played in you getting injured? Or what role, if any, is there any sort of connection between the pain, your chronic pain issue or your broken bone and these other issues? So trying to help raise awareness in the client to move that client from pre-contemplation to contemplation in this interaction we have. And then we move really into this listen and understand piece. And I think the listen and understand is really again, the meat of a brief intervention, because it's dealing with the ambivalence. And as Tom said, the ambivalence or the belief that maybe they don't have an issue at this point, that they're really sort of in pre-contemplation. How do we sort of get them to even consider the possibility of change or start to draw connections between consequences that they're experiencing and their use of a substance? So there's a couple of ways that we do this, and the real goal during this, Tom talked about a decisional balance earlier. The real goal here is to try to get them to talk about change, about the hopefulness of change, their interest in change, what change would look like for them. And we can do it through a couple of mechanisms. Tom showed you the decisional balance before, weighing pros and cons. And I think, as Tom mentioned, it's really important that we talk about, it's not just the pros and cons of using, it really is about the pros and cons of change. Sometimes people get stuck in this real ambivalence, and they get stuck because making change is hard, and making change is scary, and making change is new. And so getting them to talk about change and getting them to troubleshoot change and getting them to really think through change, and you being there supportive, is the direction we want to move with them. We talk about change talk, we sort of identify different types of change talk, and we call it like the darn C. So desire, ability, reason, need, commitment. A lot of times when a client is talking about desire, they might say, I wish I could stop, or I wish this was different. just even I wish something were different is a hook for us, because it means that they're dissatisfied in some way with the status quo, and that the possibility of change it might be small, but they're at least thinking about it. You sometimes hear clients talk about ability change talk. They'll say, well, I could if I wanted to, but I don't really need to, so I'm not going to change. But I could if I wanted to. When we hear them talk about ability, we want to actually start to move them to find out, they think they can do it, so they have a certain amount of efficacy around it. They believe they can make change if they wanted to. So we need to dig for reasons that they want to change. They just don't want to. So what are the reasons or needs? Sometimes people talk about reasons and needs. I want to get my kids back, or I want my health back. I want my driver's license back. I want to be out of the legal system. Those are reasons and needs. So when we hear that, again, we want to start moving people like that toward a commitment, or toward actually, as Tom said, furthering the conversation, or at least getting on board that we can continue to talk about change with this person. That they're not going to shut the door on a conversation, but they're going to continue to move forward with the possibility of change. In more intensive motivational interviewing training, this is the kind of stuff is really working on listening for change talk and where to go next with the client. The client says, I could if I wanted to. Where do you go next with the client so that you can continue to move the client in a way that they start verbalizing change? And they start moving toward even a commitment to change. In the video, the guy's commitment was he at least got on board that in 4 weeks when he comes back out to get his stitches out, they're going to have a conversation. And he didn't shut down the conversation. He was open to the conversation, and he agreed that in the next 4 weeks he was going to try to cut down on his own. And if he couldn't do it, he was going to check in with a doctor and take referrals. But during that process, he at least accepted that at some point in the future, we're going to have this conversation, and that I'm okay with that. So when we listen for change talk, all of this change talk right here is kind of in the direction, when we think about change talk, sometimes you hear clients talk about the not so good things about using. The bad things about using, the good things about changing. A lot of times it will start with, these are the bad things about using. This is where my use has gotten me. Maybe it played a role in an accident or something that happened. If I wasn't drinking or using, this never would have happened. It's not fun anymore. I can't afford to be in this mess again. Maybe I have legal consequences. The last thing I want to do is hurt someone, All of this is really in the direction of, I've experienced some consequences for my use. We want to take clients, it's helpful for them to talk about those consequences, for you to sort of leverage those, but we also want to steer clients in the direction of the hopefulness of change and what the possibility of change can look like, because clients can often get stuck here for a long time about, these are not so good things that have happened to me. But getting them to actually put one foot in front of the other and making change a possibility, moving them really sort of from contemplation into determination or an action phase, people get stuck sometimes many, many years in a sort of pre-contemplation or even in a determination. I'm going to do something. I'm going to do something tomorrow. I'm going to do something next week. I'm going to start my diet next week. I'm researching options. I'm going to do Jenny Craig. I'm going to do this. And they can stay in that sort of ruminating and stewing and contemplating. We want to actually pull the trigger on some of this and try to get them to move in the direction of change. So getting them to verbalize change talk and the hopefulness of change as well. How am I on time? 5, okay. I think this is a great tool that you can use with your clients when you're talking about sort of instigating or motivating change with a client, is using what we call the importance, confidence, or readiness rulers. So using a scale like on a 1 to 10 with a client, how important is it for you to change your behavior right now? So when you ask a client, how important is it for you to change your drinking, or how important is it for you to change your substance use or your smoking behavior, and having them with 1 being not important at all and 10 being just the most important thing in the world, where does your client land on sort of their importance? Now, the key to asking this question to sort of stimulate change talk is, once they give you a number, you say, why didn't you give it a lower number? So let me give you an example. You are going to change your, what's your name? Say it, Adriana? Adrina. You are going to change your heroin use. You don't look like a heroin user, but let's just play along here. Okay, so you're talking about changing some substance use, and we say, how important is it for you to change your use right now? If you give me, maybe there hasn't been too many problems, too many consequences, we've identified it, you've had some minor consequences, but you don't think it's too big of a deal, and you said, I don't know, it's not that important, a 3 or a 4. What if I ask the question, well, it's a 3 or a 4, why not a 6 or a 7? What's her, yeah, but what if I ask it the opposite? Why not a 6 or a 7? What's her response going to be? It's not a 6 or a 7. A 6 or a 7 is not that bad, right? That 6 or, I'm only a 3 or 4. A 6 or a 7 is someone who's got a real problem. I'm not that person. Okay, we never want to go there. You never, ever, 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 ever want to ask the question, why give it a higher number? You always want to say, well, you're a 3 or 4. Why not a 1 or a 2? Well, I did get arrested, or I did this. It forces you to list the consequences. It forces you to verbalize out loud something that is making it at least on your radar as a problem. So asking this question, why didn't you give it a lower number, is something we should ask for all of these, whether it's how important is it for you right now, how confident are you, or how ready are you to do this. The first question we should be asking is, why not a lower number? Why not a lower number? We force them to verbalize some consequences or a reason why things aren't working so well for them. You want to add anything? Okay. We only have a couple minutes left, so I'm going to move to options explored. Those are just a couple of tools to sometimes get the client to dig for change and to try to get them to start talking about change. Particularly if you are in a setting where the client, a healthcare setting or sometimes mental health settings, where a client is there for a different reason, they're committed to being there for that different reason, you've raised some awareness about a potential other issue, and they're really not comfortable necessarily talking about it. Oh, thought he was raising his hand. He's going to ask a question. So these are some sort of small tools that you can use to dig for change and to get them to talk about change and verbalize change. The last area of flow is really how do we explore options with them. So again, a lot of times, particularly in medical settings, this is the problem, here's our solutions, and we totally miss listening to the client. So we do want to move to exploring options once we've given them the feedback. They know what the feedback is. We've listened to them, we've heard them talk about it, we've tried to stimulate or motivate change talk, and now we need to wrap up the conversation. And we need to move them towards some sort of commitment, or where do we go from here? What is our next step? So we can talk about exploring options. And what do you think you'll do now? What changes are you considering making? What do you see as your options, and where do you go from here? If you notice in most of these stems, what happens next? In most of these question stems, the onus or the burden of change is put right back on the client. I've given you feedback as your provider. I have some concerns. Is it all right if I share them with you? These are some of my thoughts on the range of where your score fell. What are your thoughts about that? What do you make of that? You move into some motivational interviewing and some engagement. You wrap up the conversation with, where do you go from here? What are your next steps? And I think you saw the physician in the video do that, where he said, what do you want to do from here? And he's like, I guess I could probably cut back a little, or I guess I could do. So you kind of try to wrap it up and direct them towards some sort of commitment to at least continuing the conversation or making some small change. Sometimes clients might need help when you're talking about what the menu of options are, and we have to consider the range of options. I think you saw in the video, the physician didn't suggest, I think you need to stop. I think the first physician said, I think you need to stop and you're an alcoholic. He didn't say, I think you need to stop. He sort of let the client or the patient generate, well, I guess I could cut back. We need to think about the range of possibility of, maybe the client is interested in cutting down. Maybe they really think that they need to quit altogether. Maybe the client is really just thinking about reducing harm, like I don't want to drink and drive anymore, so I'm going to need to get somebody else to drive for me when I'm drinking. They may not be on board to change anything at all. Our goal is to get them to sort of commit or move forward with at least some future conversation or potential change.
But in that case, it's often a monitoring commitment. Great, don't change anything. just observe your own behavior and see
Yep.
how that works.
See how it goes for you, and can we check back in about it at a future date and see how it went. And in some cases, in a few cases, you may get clients who actually want to be referred to a higher level of care, or they acknowledge after a brief intervention that they do have some issues that they would like a higher level of care to address. Now, during the menu of options, I think it is important to always explore previous strengths, resources, and successes. You know, I've had a lot of clients that said, yeah, I'm going to stop using hard liquor and I'm just going to drink beer. You know, I'm going to stop using hard liquor, I'm only going to drink beer. Have you tried that before? Yeah, I have tried it before. How did it work? Well, you know, of course, now they're back to hard liquor by the time they're working with me in rehab. So it is okay to probe them. How did it work last time you tried that? What worked for you? What wasn't successful? What personal strengths allowed you to do it? Have you been able to stop before? What did it look like? Who helped you and what did you do? What resources did you have in place? So to try to get them to realistically think about the recipe for success for them, about what's worked in the past for them, and maybe they were successful with something else. Maybe they haven't been successful in stopping this behavior, but they were successful in doing something else. How can you leverage that or use that to motivate them to try change again? So again, have you made other kind of changes successfully in the past, and how did you accomplish these things? I think just to wrap it up, you can use the feedback sandwich that I gave you earlier about asking permission. I think it's always important to when you're giving feedback, to also say, what do you think of that, or what are your thoughts? A lot of times as you explore these options, you may have some thoughts or ideas that you think are going to be helpful to the client, based on your experience or based on other clients' experience. And so to provide that during exploring options is okay, but you'll want to couch it in, you know, based on some of my experience with other clients, I have some ideas that I think might be helpful in some of your options. Is it all right if I share them with you, or what are your thoughts? So again, using what we call that feedback sandwich to give them feedback in this way by asking for permission ahead of time, if this is advice they want to hear. When we find ourselves warning clients, I have something I think will be helpful. Is it okay if I share it with you? Sure. If this happens again, you're going to go to jail. Okay, once you start the finger wagging, you almost start the warning piece, and that usually means you're at a really different stage of readiness than your client. You're down here in action and you're working really hard for them, and they're still up here in pre-contemplation, and you gotta go back a few notches to sort of meet them where they're at to get them there.
When are you an extension of your probation officer, and when aren't you an extension of your probation officer? And giving the client that information, it's amazing how much people will tell on themselves if they think you're telling them the truth about where they are. It's much more complicated than that, and I can't solve your particular issue right now in the few minutes that we have, but I think that that's the core of what we're talking about. The relationship needs to be based on trust, and they need to know that you know that they know that you are in some ways an extension of their probation officer. So truth is what wins out ultimately. Yeah, SAMHSA also has a publication called Tip 35. Bill Miller put out a book. It's really good. It's all based on theory. It's very dry and very boring to read. And it doesn't really tell you a lot to do, but it gives you the foundation for understanding the theory. The motivational interviewing tip, which is free, you've already paid for it with your tax dollars. You can just go to samhsa.gov, order Tip 35, and it's really concrete tools you can use on an ongoing basis. But your homework, give feedback to someone in a way that's motivational, and then listen. You'll change their world, and it'll change your world. Our contact information is there. We're happy to answer additional questions. If you're leaving today, thank you very much.
Thank you.